Welcome to EMS Challenge. We are live at Prattville Fire and Rescue. Thanks, guys, for hosting us. Super appreciate it. Today, we got myself and Dr. Kirby, one of the EMS fellows, talking. I'm going to go over some ocular emergencies, and I think you're doing toxicology. Is that right? So good stuff online. If you're in the area, please come out. We'll do lunch at 11, and then we're going to do some skill lab. So the goal will be we're going to go over some ultrasound training techniques. I know a lot of places are moving to ultrasounds. I got a few I can show you as well. Most of them have AI, which is great because it labels anatomy for you, makes it a lot more realistic, and it gives you the ability to kind of train with that stuff when you don't have access to patients in the hospital. So we'll go with ultrasounds. We'll do some cardiac arrest training and some airway management training as well. So a lot of good things today. And then just kind of a Q&A laid back with me and Dr. Kirby. Forgive me, I did have a Mountain Dew and a little Debbie snack cake this morning, and I am pinging like crazy, so I apologize. It was good, though. Hopefully my wife's not watching. Disclosures, I'm not going to say you anything. I will give you some opinions, but no disclosures, except we are supported by the Fire College. Super appreciate those guys. History of EMS Challenge, if you're not familiar, we started this about 10 years ago to bring more physician-led Con Ed out in the field. If you heard me say it once, you've heard me say it 10 times. I think that the care that the paramedics provide in our state is physician-level skills. We as healthcare, as physicians, should be involved in that and help support you. It is unfair of us not to do so. So that is one of the goals that we're doing this. I'm pleased to say that the Fire College supports this. UAB Department of Emergency Medicine is very pro EMS at this point in the game. We have a fellowship, which is 2 docs a year that have completed ER training and doing pre-hospital medicine with me. And then every month I get an ER resident. We also have access to the medical stools. So first-year med students have the ability to take an EMT class now. Okay, and then our second-year med students can come back and do like a physician skills in the ER. And the reason I'm saying this is not because I think these guys are going to go out and do pre-hospital care, but what they are going to do is in 10 years from now, that med student who's now the chair of OB somewhere is going to allow us as EMS providers to go in and train with them. So hopefully we're building these relationships and memories that 10 years from now kind of reap some benefit for education and backing. I show this slide in most of the classes I do. This is my inappropriate humor that says this is the state of American healthcare. Ha 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 ha, right? Yeah. The good news is EMS is out there to help and make things better. If you look what you guys did during COVID, you were asked to do a lot of things out of the general scope. And every year, if you look at the things that we're allowed to do by the state and through National Registry, it keeps increasing. Mainstream healthcare needs you guys. So EMS is the way you put out this dumpster fire we call healthcare. And that's an inappropriate shout out to the Fire College. Thanks for your support. Oh, look, we got power in the back too. I like this. Very good. Yes, sir. You can sit in my seat if you like to, sir. Just don't drink my Coke. That's all I ask. Cool. I'm going to talk about ocular or vision difficulties, so that's why I threw that up there. I also wanted to give a shout out to the Fish concert. Any Fish fans here? Good. Thank you. Praise God. So they had a concert in Birmingham last week that was very interesting, so we'll leave it at that. One of the things we talked about at the MDAC yesterday in the BREMS region is quality improvement. So the state requires you to have a quality improvement plan. My advice, suggestion for that is if you have a plan, follow the plan, right? So you got to be able to do that. This is access. If you want to use the one that I use the places that I work with in BREMS, this is an optional plan for you. It gives some insight into things that we do. Feel free to scan that QR code and you can download that and look at that. I would say talk to your medical director, modify it as needed that fits your needs of your system. But if you have a plan, please follow the plan. Cool. All right, let's talk about eyeballs. So external anatomy of the eye. There are not a lot of ocular emergencies out there, but the ones that are important because imagine doing your job with one eye closed, right? It'd be very challenging. I know we have some firefighters in our state that are able to do their job with one eye, but you ask them and they will tell you that it's difficult working a scene with one eye. You need both. So we should be able to recognize abnormalities and determine, does this go to a local ER? Is this something that goes to a specialty place? Or what do we do with that? So my anatomy of the eyeball is the eye is a big ball of goo, right? So you got 2 chambers in the eye. You got the anterior chamber and the posterior chamber. The anterior chamber is the clear portion that we can see if you make eye contact with somebody. The posterior chamber is a bunch of gel, okay? You have the neurovascular bundle in the back that has the ability where you kind of make the neurons where you can see. And the vascular structure of the eye kind of surrounds the eye. You can't run vessels through that middle ball of goo because you wouldn't be able to see. You have your lens, you have your muscle that adjusts the aperture so you can get light in. So a lot of important things to the eye. If you think about the docs that take care of eye emergencies, these guys do med school and they get 4 years of nothing but eye. So pretty important things, very delicate. And again, you do not want to lose that eyesight. So anterior chamber is what you see. Posterior chamber, vascular bed with neurovascular bundle, some muscles around it. Okay. The way the eye is fed, it gets its nutrition, is the blood supply goes in and then it kind of permeates through this way. There's no real good supply to the anterior chamber for the most part. So fluid from the posterior chamber runs through and comes back to these canals here. So it's a pretty complicated pathway to get nutrients, oxygen, glucose to the eye. So you got this guy minding his own business at a local bar. He gets hit across the face with a beer bottle. On TV, that looks pretty cool. In real life, it does not work well. Somebody's got a radio. If y'all can turn that one down just a little bit, I appreciate. Thank you, sir. Appreciate you. So he says he's nauseous. He's got blurry vision. You look at his pupils, because I know everybody does. Takes a quick look at his face, and you see this. What's going on here? And you can say it's gross if you want to. Anybody like eyeballs? Raise your hand if you like eyeballs. Oh, good. One person, 2 people. Very good. Yeah. Normal or abnormal? Very good. We're going the right direction. Very good. Abnormal. Yeah. So what's going on here is you have a laceration of this anterior chamber. Okay. And because the eyeball is a big ball of goo, if you cut something here, it's almost like a squishy toy. Anybody got kids that have squishy toys? What happens when the dog bites it or you cut it? Squirts out. So that's what's going on here. I like this firefighter talk. Squirts out. I like that. Yes. Are you an officer? I can't read your shirt. Oh, yes, yes. It says deputy chief, I think, doesn't it? Yeah, so it squirts out. So what you've done is you cut this anterior chamber, and now the inside of the eye is coming out. So this is bad. This is vision-threatening injury, right? It may not be life-threatening, but it's definitely going to change his vision, which potentially could change his career and things that he does. So we should better recognize that is abnormal. So what is the fancy medical term for that called? Anybody know? So if I'm calling ophthalmology, I'm going to say, I got this guy, he's got a jacked up injury, right? Now, it's an open globe. That's what that's called. Open globe injury, open fracture, open globe, right? So how do you treat this? What do you do for this? Yeah, what do you cover it with? No, normally you would. Good call. Most injuries you do. This one, you really don't want to poke it. What happens if you poke it? More comes out, makes it worse. Yeah. So really what you want to do is you want to cover it with something so that it doesn't get more pressure. If you have nothing that can cover the eyes, then you don't want to do anything to it, okay? Because you definitely don't want to cause any increased intraocular pressure. So historically, we talked about putting a metal eye shield over it. My experience is most times those don't fit and they end up sliding around. You put an eye shield on, you wrap it with Coban or Ace Wrap, and it moves over and ends up pushing on the eye, okay? So not a good way to do it. In the hospital, if I have a compliant patient that's reasonable, I'll put a cup or maybe an emesis basin over that eye, okay? A guy at a bar who just took a bottle to his forehead has probably been drinking a little bit, right? So he may not tolerate that well. So sometimes what you do is you want to cover both eyes. So a big bucket, emesis basin, something like that. Inappropriate humor, you put a bucket on his head, put 2 buckets on his head, right? I think that was Montgomery, not Prattville. Y'all don't have people that do weird things, do you? Yeah, no comment. Yeah. So as far as treatment goes, the main thing is you want to recognize the injury. If you don't recognize it, you're not going to be able to treat it. You want to cover it if able and to do it without being able to put direct pressure on it, okay? And then you want to help decrease intraocular pressure by controlling pain with medications such as fentanyl or your morphine. Probably would not do ketamine. You can. Historically, we talked about ketamine, increased intraocular pressure, intracranial pressure. That's kind of been debunked. But what you don't want to do is give this guy enough ketamine that he starts tripping and acting weird and being more combative and gets anxious, because what happens when that happens is increased intraocular pressure, more of the inside of the eye comes out, you get worse outcomes. So fentanyl, morphine, if they're nauseous, I like vomit. Vomit's a great body fluid, right? So he can get some other medicines such as Zofran. Yeah, Zofran's a great medication. Okay. Obviously, this person is going to need an ophthalmologist, so those are hard to find in the ERs because that is usually a cash up front business. Hope none are listening to me. But this person needs to go to a place where they can get the ophtho. In the greater Birmingham area, we have access to that at UAB. We also have a dedicated IER. Then I know that Huntsville has some access, as does Mobile. I'm not sure about Montgomery. Y'all have a place that can do eye stuff back to South? Have ophtho? Yeah, they don't. Yeah. So obviously, this person is going to need to see an ophthalmologist, not an ophthalmologist. Okay. So what if they're drunk? What are you gonna do with these guys? They're agitated, they're drunk, kind of combative. What are the things you can think about for this guy? I would argue this is not a life or limb threatening, but it's a vision threatening. So this is emergent. This is somebody that you need to consider, making sure they get evaluated. This is a med control phone call. Other medicines you can use to help them relax now in our state protocols if they're a little bit anxious or agitated, or if you call med control. There's some good medicines out there, kind of rhymes with this guy's name. Anybody know what it might be? Yeah, very good. Somebody finally got my joke. I like that. Thank you, ma'am. You get a challenge coin too. Very good. Yeah. Yeah. So benzos are great. So Versed, Ativan, Valium, those things are great. It kind of chillaxes them so they're not so anxious. The other benefit to benzos is benzodiazepines are a great antiemetic. It's one of the best nausea stopping medicines we got. We don't tell people because we tell people our fears that the patient can say, yeah, I'm allergic to Zofran, to phenergan, to compazine, to Benadryl, everything but benzos for my nausea, right? So don't tell anybody, all right? But benzos are great for nausea. Cool. Other things to think about if you're critical care is if this patient was in my ER, they were intoxicated, did not have capacity, could not demonstrate the risk to benefit of therapy or non-therapy, and they're agitated, this is somebody just like the guy who's intoxicated and a trauma patient. You take their airway, you sedate them, you paralyze them, you take their airway. They're going to go to the OR anyway, but this is a pretty significant injury. So if I had this guy in the ER and he was agitated, he was vomiting, couldn't control it with my Zofran, my fentanyl, with the benzos, he still didn't have capacity because he'd been drinking, got hit across the head with a beer. This is somebody that I would consider early RSI on this guy, lowering his blood pressure, dropping him down, decreasing intraocular pressure to save his vision long term. So this is a critical patient that needs expert care. Cool. You can label these by in zones, kind of give them a class. There's zone 1, which is the anterior chamber that you can kind of see. Zone 2 is a little bit deeper, and zone 3 is like the meaty part of the back posterior chamber. I would argue that zone 1s we can see as ER or EMS providers. Zone 2 and 3 is usually penetrating injuries that you can't recognize. If you have a zone 2 or zone 3 injury, what is your bigger concern for this patient? Underlying head injury, right? So you think about some kind of head injury as well, and that takes precedence over the eye. But the therapeutics, the things we do for the eye, will also benefit the head, kind of the same mainstay of care. All right. So the Eye Foundation at UAB, they have a separate ER. There's only a few of those in the nation, so I know that we are blessed, and we kind of get to cheat in the city of Birmingham because of that. The way the eye docs talk about their emergent cares, they use something called ACT Jello, and it's a mnemonic they use, which is assess, categorize, and triage. And their triage is, does it go to the main ER or go to the Callahan? But you can use that same mnemonic to kind of figure out how you're going to manage these eyes, right? So the Jello is gross external examination for eye integrity. That means you look at the eye. You can do that anyway. It says light palpation for orbital pressure. I don't touch eyeballs with my hands. If it's an open globe, I can make it worse. If it's a not open globe, nobody appreciates it being poked in the eye. So my advice is we don't touch the eyeballs, right? And then ocular vital signs. And the vital signs are visual acuity. And you can be fancy and pull out that little card that we use at the hospital and say, can you read this? In reality, it's like pull out your badge. Hey, can you read this? How many fingers do you see? Make an inappropriate gesture if you want to. That's fine too. You're just looking for what is a gross vision. Intraocular pressure. If there's no signs of trauma, you can do a Tonopin. Nobody in our state is carrying that. In the ERs, we can do that. We're checking for pupils. We're looking for reactivity. Extraocular movements is making them look, hey, look up, look down, look left, look right, fake a smile, sort of like you do for your stroke assessment, right? And then confrontational visual fields, nobody's doing that. I'm not even doing that. Just don't tell my boss at work that. Sweet. So in reality, what you're doing is you're looking at the eye for external examination, any obvious signs of trauma, ocular vital signs. Hey, sir, can you see me okay? How many fingers do I got? Do you wear glasses? How's your vision? Okay. All right. Pupils, I've already checked reactivity. And then, hey, left, right, up, down, what do you have? And that gives you a lot of information is do they have some kind of significant underlying ocular injury? I used to talk about we don't check intraocular pressure a lot because it's complicated until I got more mature in life and started seeing the retina guy, right, the older guy. And I realized the person checking my eye pressures in that clinic was probably a 16-year-old high school kid. So I figured if they can do it, I can do it too. But you got to have the equipment, all right? So quick pupillary exam with your flashlight, your pen light, and then look up, look down, look left, look right. That gives you good access to see is there any kind of injury. And it also tells you if they can move that eye, there's no orbital fracture, no underlying facial trauma for that person for the most part. Cool. For the folks in the hospital, if you think about Tonopin numbers, there are a lot of numbers out there. I use 5 to 15 as a great intraocular pressure. Anything too low is concerning, probably means you didn't do it right. And that's the eye sunken back in the head. And if it is, you shouldn't be poking it anyway. And greater than 15 makes you think you got some kind of injury causing increased intraocular pressure. Cool. All right, so that was a kind of open globe. You want to? Oh. So cellulitis of the eye, this can be bad. So you got what we call orbital or preorbital, or septal or preseptal, different, same thing, but just different phrases for it, all right? And the problem is if you get an infection around the eye and it stays on the outside, no harm, no foul, it's just the face. We can treat that with antibiotics, no long-term outcome. If you get an infection under the septum, kind of like behind that muscle there, where the eye sits behind, that leads a direct pathway to what's behind the eyeball. The optic nerve in the brain, right? So this is a direct path to get meningitis. So eye infections that are deep tissue infections are high risk to cause meningitis. Those guys are admitted, they get IV antibiotics. They get to be boarded in an ER somewhere in our state for a couple of days so they get a room. Those are high risk for having bad outcomes. If the infection is on the outside, those guys can be evaluated in the ER, recognized as probably not orbital, and they can go home. My point to that for you guys is facial swelling concerns of cellulitis, redness around the eye, they should be evaluated by an ER doc because there is a risk for bad outcomes if we miss deep tissue infection for those guys. One of the ways we check for that is we do this. If that pupil is sluggish to react, if they can't move that eye because it hurts, that tells you there's pus or infection in the muscles around the eye. And that's a hint. Oh, you probably have a deep tissue infection. You get antibiotics, you get admitted, all right? In today's world, they get a CAT scan. But also in today's world, has anybody been to an ER lately and tried to get a CAT scan when you weren't a trauma or stroke patient? Raise your hand. What's the turnaround time for those? Forever. Thank you very much. Very good. Forever. Yeah, so it's complicated, right? Healthcare is in a unique state right now. So inpatient or outpatient. Sometimes these things can be confused with histamine responses or trauma, so you got to do a good history. If their face is red and swollen and they just left a bar, they probably got hit. All right, so how would you check for an open globe injury on this patient? Separate the eyes? Yeah, you might try once. If they say, ouch, I would stop because they have an open globe and you do a lot of pressure, you make it worse. If they don't, no harm, no foul. They go to the hospital, they get evaluated. We can cheat and get scans to look for a globe injury if we can't look at the eye. But it could be histamine. If they had a recent food allergy or something, you can treat it that way. So always think about the causes of this. The biggest concern for this guy would be infection, cellulitis, deep tissue, potential meningitis, or some kind of ocular injury from trauma. All right, cool. This is an oldie but a goodie. And that's another oldie but a goodie. That's more for Chief Ward's generation, if he remembers that skit, but I'll be quiet. Cool. And, you know, Will Smith was a nice kid at one point. But blunt force trauma to the eye, you can get this. Anybody know what that's called? Hyphema. Yeah. So it's blood of that anterior chamber. We know that the anterior chamber has a little bit of blood supply, not a lot. So if you get blood in there, it's pretty significant force that caused that. There's certain medications that people take now that can make this a higher risk for them. What medications does 80% of Alabamians take now? And don't say what now? Blood thinners, yeah. I thought somebody say insulin or meth. That was funny. Maybe not. All right. So blood thinners, yeah. So that's a question you ask every patient you take care of. It kind of changes the pathway we take care of them. But this is a high FEMA. Historically, in EMS, we didn't find these until they were in the ER. You brought them in on the backboard from the car wreck and blunt force trauma. I've done my workup. It's 4 hours later. I cleared them off the backboard. I sit them up. They start walking around. I go to tell them, hey, you're fine. You're going to be great. Here's some motion and 3-day work note, Alexander Chenard's business card, make that call. And I look and say, oh, yeah, eye looks kind of funky. And I look at it because they were laying flat and it kind of layered out. We don't bore people as much anymore by the long backboards. So these are more common. And this is usually a delayed response that we see in the ER that you guys won't see. But if you see this, it's definitely concerning, right? So you can grade these. We kind of talked about the blood. Talked about that. You can grade these based on percentage, right? So, and it kind of gives you an idea of their chance of recovery. So even 100% blood, entire eyes full of blood, you still got about a 50-50 chance of getting a 20/50 or better vision long term. That's if there's no other underlying injury. I would argue if you're not anticoagulated and you're seeing these big bleeds like this, you probably have some kind of injury to the globe or something else going on as well. So that one's pretty impressive. That one's kind of layered out, been sitting there for a while. But with this one, we got probably a 90% chance with appropriate therapy to get recovery for this, all right? So the way we treat these things is we have to recognize to see that they happen. We have to determine, are you anticoagulated or antiplatelets? Do we need to stop those for a while to make this better, or is the risk of stopping it worse? We can also go in, we give you drops in your eye to dilate this eye, because what we don't want to do is have this blood here. It gets kind of thick and chunky, and now this pupil is getting big in the dark and small in the light, right? And it's pulling and it tears this tissue, the iris, and it causes some injury to that globe itself. So we want to make that eye relax. So even if we covered that eye, if you're using your other eye, it's going to react and get big and small. The pupil will. So we put drops in this eye to make that pupil get really big so you don't cause tearing, okay? The other thing to think about is, even though I talk about you get about 9% of people get vision back to 20/50 or better, that's 20/20, that's 20/40. That's still a deficit for some people, right? So even though it's not a bad outcome, it's still not a good outcome. So early recognition, intervening, getting to the hospital so we can take care of those patients is super important. The eyes are needed. So we talked about dilating these folks. Cool. That's another big one as well. So we see more and more of these, mostly because of folks are anticoagulated or antiplatelets. That's inappropriate humor for the fire service. And nobody thinks it's funny. I think it's hilarious, but it's not. It's going to get worse, guys. I promise you. I got more fireman jokes. All right, this is a young female in her 60s. Her blood pressure is 190/94. Heart rate's in the 80s. Respirations are 16. Her pupils are unequal when you look at her. She's got a little bit of a headache, a little bit of nausea and vomiting. The rest of your IMSA scale, what you're going to do, because you're thinking, oh, she's got unequal pupils, I got to make sure she's not having a stroke. The rest of her IMSA is fine. She can talk to you. She can track. She can move everything. She's not been in a trauma. Nobody's jacked her or anything. What's going on with this lady? But first off, what do you think about the blood pressure? Too high, too low, or okay? It's Alabama. That's normal, guys. Yeah. So I would say it's moderate. From an ER doctor perspective, yeah, I'm not concerned about it. From a general health population, yeah, it needs to be evaluated and slowly worked down, but that one number doesn't scare me. What's going on with this lady? You got a non-reactive one pupil. You got this haziness to it. You got this shiny rim on the outside. She can move her eye. She can talk to you. She moves everything. She's got a headache, a little bit nauseous. Anybody know what's going on with her? Do what now? Yeah, you think ICP? Yeah, you could think ICP. Yeah, but she's moving everything. I would think if you had a generalized increased intracranial pressure, she can have other neurological symptoms. Could be cataracts. Yeah, kind of weird to have cataract on one and not the other eye, but could be. It's a good question. Nah, I think that would probably cause other neurological symptoms as well. Oh, this is good. I got y'all tricked. What does that make you think of? That's the treatment for this. Glaucoma. There you go. Yeah, yeah. This is glaucoma. Look at that. That's pretty good, isn't it? I'm a doctor, right? I'm a doctor. Yeah. So this is glaucoma, right? So this is acute angle glaucoma. This is not the glaucoma you get when you get older. Anybody, any age can get this, okay? Usually they have headaches, they have nausea, the vomiting, they got some visual changes, but the neuro intact, walkie-talkie, nothing systemic, is all ocular related. It can trick you sometimes, and I'm glad that y'all are all thinking big bad things first. This is also big and bad. If we don't treat this soon, you probably got 4, 6 hours until this increased pressure on the eye causes optic nerve damage, and they start losing vision. So super scary, right? So what's going on here is that for some reason that fluid I mentioned earlier that we make back here goes into this anterior chamber, and now that fluid can't leave that chamber. So this guy's squirting fluid into this chamber to give it nutrients, and this gets more and more pressure and starts pushing all this back. So fluid comes around and goes out in this canal here, and I can't say that word without making it sound inappropriate, but it goes around the iris and then back through some canals. The problem is, as this pressure gets high, this pupil dilates, and as it dilates, that angle gets shorter or smaller and less fluid goes out. So it kind of self-propagates. It gets worse because of the own condition. So super concerning. You got to recognize, if you don't recognize it early, people will lose their vision. So what you see is a fixed pupil that's non-reactive, that can still move, and the patient is neuro intact, walkie-talkie, cloudy cornea, okay? My point to that is anybody with a headache, anybody with nausea, vomiting, always look at their eyes, do a pupillary exam. You do it now on everybody anyway. I would say y'all do it on every cardiac arrest, y'all do it on every overdose, you're looking at the pupils. Just take a quick look and see what you got for these headaches as well. The way we treat this, we want to constrict the pupil. With the blood in the eye, we want to make it big, dilated. With this one, I want to constrict it, because when I constrict it, that angle goes from here to way over here and more fluid goes out. So I put drops in them that makes the pupil constrict, all right? I can give them drops in the eye. They're beta blocker drops, just like the beta blockers that we use for heart medicines, except they're drops in the eye. And that makes the fluid in the back part of the eye quit making that fluid, so less fluid goes in. So it stops the increased pressure, but it doesn't do anything about the current pressure, okay? The ophthalmologist or even the optometrist, the guys at Walmart, can do this. They can go in and they can drain some of this fluid out now, right? So they can go in with a laser and drain it out. And actually what I see in the ER a lot of times is these pressures are high. They have that vision loss. We can't get it better with drops over the course of 15 or 30 minutes. They're going to go in with a needle and aspirate and get the fluid out, and that fixes the problem. I cannot do that. That grosses me out. If I'm coming at you with a needle, you better hope that you're paralyzed, sedated, intubated, and there's no one else around, because it's not good. Cool. But that's acute angle glaucoma. So we got this dude here. This pupil is fixed and non-reactive. It's kind of looking that way. This one is fine. So I'm going to do my assessment and get in my history, no injuries, no trauma, not on blood thinners, right? Look up, look down, look left, look right. I'm doing all my ocular vital signs on this guy. And I got to think about what's making this pupil get big. To your thought process now, you should think acute angle glaucoma. Is there a globe injury, things of that nature? You can also think about certain strokes in clinical pictures. And nobody's going to remember this, or maybe if you do, you're better than me. I can't remember those things. So I have 3 roles, and I call them my thoughts on this, Ferguson's thoughts on this subject. If you have a fixed pupil that's down and out, so I got a guy that's alert, walkie-talkie, neuro intact, moves everything. He's got one pupil that's fixed and dilated, and it's looking down and out, and he can't move it. Probably not acute angle, because with acute angle, you can move the eye, all right? That is an aneurysm in the brain until proven otherwise. That is an emergent patient. because that means the aneurysm is so big that it's pressing on the optic nerve. And we need to diagnose that and get them to a neurosurgeon to clip it, to coil it, or take it out before it ruptures. And then they have that subdural or head bleed. And that's bad. People die from those. So what's going on is you got this vessel that runs along where the optic nerve is. That vessel gets big, it pushes pressure on it, and now that person's eye does not work. Okay? So a fixed pupil that does not move, all right, neuro intact makes me think aneurysm. Fixed pupil that moves, neuro intact, makes me think acute angle glaucoma. All right? So fixed, non-reactive, but moves is acute angle glaucoma we talked about. And then a fixed pupil that is non-reactive in any other neurological sign is a stroke or head bleed to proven otherwise. So that makes it pretty simple, okay? Now, you can get way in the weeds with this, but that would give you a way to kind of look at these guys on scene and figure out why is that pupil jacked up and what I should do with it. Does that make sense? Questions, comments, statements within reason? Good, nobody's even smiling. I like this. Great, great. All right, so this dude was punched in the face. You're doing your exam, pupils are reactive. All right, look up, look down, and you realize this eye is moving everywhere he goes, but this eye is not moving. Pupil is reactive. You see no signs of an open globe. What's going on with this dude? Does anybody care? Nobody cares. If it's your kid, would you care? Some of you still say no. Good, great, yeah, that's wonderful. All right, so this is entrapment. This is that eye can't move, and what's going on here? The orbital rim here is really strong, takes a beating. The bones inside the eye are like bird bones, real thin. So he had some kind of injury that pushed that eye back and broke some of those small bones. And when that happens, the muscles that control the eye get stuck in those broken bones. So the eye doesn't move. It's called entrapment. So by the fact he can't move that eye, you know he's got facial fractures, all right? The bigger concern for this guy is two things. Is there a globe injury? Because it takes a lot of force to do that. Or more scary, was that force enough to cause some kind of head injury? So that potentially could be a bad patient, right? Cool. So, but I pick it up on my exam. Hey, dude, what happened to you? Oh, you got punched. Sorry, bad day. Checking your pupils, look up, look down. Oh, that ain't working. I start thinking right now, okay, potential globe injury versus potential head injury due to the fact he's got facial fractures and entrapment. And that's just part of your secondary exam, okay? Cool. These guys usually have pain. A lot of times if they can move even a little bit, it hurts a lot, they won't do it. But the concern for these guys is a globe injury or underlying cranial injury. So he gets the same questions as everybody else. Hey, are you on blood thinners? Yes or no. Changes disposition sometimes. Sometimes in the hospital, once we rule out globe injury and head injury and everything else, and they don't have like an optic neuritis, these guys can go home and we can fix these operatively the next week. You can wait for that, but not to rule out the big bad things. This is just a swiped photo off the interweb, and you can see you got a fracture of the floor of that orbit, and you got entrapment of muscle and orbital fat. Yes, you can have fat eyes too. It is Alabama, right? So orbital fat, so that eye will not move. Good news is you see no blood in the head, right? So that's the good news. Cool. So corneal abrasions. I know a lot of you guys have heard about these. From an ER perspective, it's kind of secondary, not super crazy, but you want to be concerned about it. You can get some of these that are pretty deep. They can cause some long-term problems, especially in people who are immunocompromised, the elderly, or diabetics. Lots of causes for them, but basically it's a scratch on that anterior chamber's external surface. Now, the good news is that's sort of like a fingernail or skin. It grows pretty quick. So most of the time they heal pretty good as long as they aren't full thickness or you have some underlying health problem. The way we diagnose these in the ERs, we take a history. Oh, you are messing around with somebody, they slapped you, may have scratched your eye, you got some visual complaints. I do my ocular vital signs, make sure everything moves, and then I put some a numbing medicine on the eye. I put a drop of fluorescein. The eye where that scratch is takes that fluorescein up, and we can see it under a woods lamp. Okay. Free vision. All right, take your knowledge and go. Yeah, that's what I'm talking about. Yeah. Talking about a bunch of stuff. So the trick to this is in the hospital, for you guys in the hospital, if you got somebody with an eye complaint and you're dropping tetracrine in that eye and the tetracrine fixes their problem, it's not a deep injury. It's not a globe. It's not central. You're like, great, wonderful. I fixed the problem with this. I can look for other things, but I know there's nothing bad. They're not going to lose vision because of that. So tetracrine is a great diagnostic thing. One of the biggest complaints with these corneal abrasions is blurry vision. So y'all can read that. Yeah, it's inappropriate. Or that's funny too, and that'll make you have blurry vision. There you go. Thank you very much. Delayed response. All right. So corneal abrasions, they can be bad, but they can be managed. The good news is these things can also be managed by optometry. So the guy at the Walmart that does that, so those are reasonable places for these guys. I am not saying you get on scene to take care of a patient and they want to go to the optometrist, you take them there. What I'm saying, this is for your general knowledge that optometrists can manage this if it's just a corneal abrasion. That eye looks jacked up. It is white. It's got white stuff in it. So instead of blood, what is that? It could also just be pus, right? So a lot of times you see these eye infections in patients who are diabetics or older. Somebody who was post-cataract surgery, post-retinal surgery, they'll get infections like this. Or the guy that had an open globe 3 weeks ago can get these as well. Obviously, an eye that has been dead for years can look like this. So obviously ask your patient, hey, do you normally see out of that eye that looks like Jack right now? Don't phrase it like that. This is the toughest crowd, Chief, we've had in a while. You know what I'm saying? I know. Yeah, I know. All right, fair enough. Cool. You can also get burns and chemical burns. I won't go deep into this. The big thing to remember this is that alkali burns are bad. These guys need irrigation, and you can start that in the field. All right. In the hospitals, you can use, if you don't have ocular strips to look for pH, you can use the urinary strips as well. That works pretty good. Folks are not going to like this who have ocular injuries, burns, either from alkali or acids. They're going to need medications to help them relax while you evaluate, check the pH, and treat these things. Morgan lenses in the hospital, these are great. They're pretty cheap. That hooks up directly to your IV tubing, and it's like a contact lens you can irrigate. A lot of the times before we do these, we're using nasal cannulas, other ways to start irrigation to get that started on these folks while we look for this in the ER. But a couple of drops of tetracaine, check the pH. You've already done your ocular exam. You know they have exposure to some kind of chemical. At that point, you're going to start irrigating, and you irrigate till their pH is normal. And normal pH depends on that pH paper sometimes. So I would check the pH of the unaffected eye and see what that is, and that's the goal for the affected eye. Because sometimes your paper sits in a drawer in the ER for 6 months, and it changes the way it looks. But you can use nasal cannulas. That works well. If you work at an industrial place that has an eye washing station, use that like crazy. Some states, EMTs even use tetracaine, and they put tetracaine in and can wash out. We can't use tetracaine at this point, and that's probably okay still. All right, this might wake a few of you firemen up. What about this one? What do you think about that eye? Your concerns for this patient? Yes, sir. I agree with that statement. Yes. Yeah. So, yep, your eye looks bad, sir. I'm more concerned about head injuries and other injuries for this guy, right? So, eyes hanging out. Looks like we have blood in that anterior chamber, and we know that those are bad. If he had just that, he has what, a 50% chance of survival or vision survival if we give him the appropriate therapy pretty soon. But my bigger concern would be, is there some kind of underlying injury to the brain? So, infection, secondary injury as well is super concerning. So what happened to you? What's going on? How would you manage this wound for the eye? How would you transport this guy? He's laying there on scene, his eyes kind of flopped out. You got this injury. He's alert, he's mentating well, blood pressures are fine, and this was like a crowbar to the face. That was a good one. Yeah, that's good. Even the nursing home can make jokes sometimes, right? Yeah. So we talked about a metal shield earlier. Probably not appropriate. We talked about putting like a bucket or something over the head. Probably not appropriate. This one, I'm going to do what you said earlier, whoever said it. And this was probably going to be, yeah, don't want to put a lot of pressure on the eye, but I can't go down Highway 65 at 80 miles an hour because it's going to be flopping and jumping, right? So it's going to be saline gauze over that, kind of push it over, gentle bulky dressing without Coban or Ace wraps, and manage that way. So that is a bad injury. What about this one? So said he was weed eating and felt something hit him in the eye. Now he's got blurry vision, hurts to move it. He can move it. It's reactive. It's asymmetric. What do you think about that one? Yeah, so I think he's got an open globe. That should be circular, right? And it's not. It's kind of teardrop shaped, right? Looks kind of funky. So that is an open globe to proven otherwise. So I'm not going to be poking it or anything. I'm going to control his pain, control his nausea. I'm going to cover it, cover both of them I can. And he goes to the ER with, and when you get there, you say that magic phrase, hey, doc, I think he's got an open globe. That doc should put out the cigarette, stand up, and go evaluate your patient at that point. Okay? If you say he's got something in his eye, he's got blurry vision, we would get up, but we may finish our sandwich first, right? Cool. No, that's a good one. Yeah. What's the biggest concern for this guy? Yeah. Yeah. Who shot him in the eye with a nail? Where's the lady that did that, right? Make sure she's already left the scene, right? Yeah. So obviously, I'm thinking intracranial. How deep is it? Does he have a head injury? I am not. I may check my pupil response. I'm not going to say look left, look right, because it's going to kind of scrape, right? Yeah, exactly. Makes it worse, right? So obviously, this is one you want to stabilize. You want to have him close both eyes. The unaffected eye needs to be closed and relaxed as well, so he's not looking around because that eye will track the same way. He gets pain control. He gets management for intracranial hemorrhage because you assume he has one to proven otherwise, right? Cool. Talks about a little bit of hyphema. Yeah, who cares? He's got a nail in it, right? Sweet. Oh, that's a cool show. I mean, watch that show. Nailed it. No, I guess not. I guess it's just me at 2 in the morning that can't sleep. Well, that one. Anticoagulated, hanging out at the local jail, gets punched by somebody. Anticoagulated, face is vascular. This bleeds pretty quickly. All right, so we got a huge hyphema, completely closed. We got all this tissue that's big red swollen. This is swollen. This is also an ocular emergency. He probably has increased intraocular pressure. We would look at this as an ER physician would say, yeah, this guy he definitely needs imaging. If I can't get it done right now, he probably gets a lateral canthotomy. When we go in, we cut the tissues here so it does not cause so much pressure on the eye as it swells. So hyphema, hemorrhagic chemosis, the lateral canthus, that's what we want to cut. And that kind of untethers the eye so it doesn't put tension on that retinal artery nerve. This is an older person that fell, and now they have a fixed pupil on this side. All right, they cannot move. A lot of facial swelling. So, yeah, right. And you never get a straight answer with that, do you? Yeah, it could have been today, it could have been yesterday. Yeah, so thinking, do you have blood thinners? What's going on? I'm always thinking underlying head injury. If they can't move that eye, I'm thinking there's entrapment, so I have a facial fracture. So I'm thinking probably potentially a globe injury or a head injury as well. So this is another guy that got punched in the face. He's got blurry vision. It's really hard to get a good exam on him. So you can take your gloves and force his eye open, but if he has an open globe, I'll make it worse. So it's a gentle attachment, touch to try to open the eye. If that works, great. If I can make him look left and right, up and down, I can do an evaluation. If not, it's pain control, antiemetics. I'm not going to irrigate it. He's going to go to scanner and look for an open globe injury so that he does not have a bad outcome. And obviously, I'm asking the same questions. Are you on blood thinners? Doing my neuro exam. Think about closed head injuries as well. So some of these wounds are pretty devastating. And all these wounds end up needing ophthalmology, the eye doctor surgeons to see. The question here, is this a clot from a laceration in the eyelid? Or is that posterior chamber coming out the front hole of the anterior chamber, right? So I probably would not be taking the gauze and wiping that. It's, yeah, I bet your eye does hurt. If I can open and look, great, give me an exam. If I can't, dress it and get to a place that has ophtho surgery. Oh, that's inappropriate humor. I'll change that quickly. Eyelid lacerations, local ER doc. So if I was a doc working at a local ER and you brought this to me, I would thank you very much for your service. Be polite. Hey, if you need anything, let me know. Give me a call. In my brain, I'm calling you names and the patient names because I can't fix this. This has to be fixed by an ophthalmology guy. The problem is, if I sew this up, my suture is going to stick out the backside of that, and every time the guy blinks, he gets a corneal abrasion. So not much I can do for that. Now, I get it. If you're not working at a place that has an ophthalmologist close, you can't drive an hour and a half to take them to the eye specialist. I understand that. But my point to that is this needs a specialist to manage it. Sometimes plastic surgeons can do that. So if you work in a community, you have a plastic surgeon guy that lives there, you can sweet talk them, give them some bling, then ride in the fire truck, things like that. And maybe they'll come in and cover these for you. But that takes a dedicated specialist because, again, the eye is super important. How much time we got? Young guy, 46-year-old, painless vision loss. That's also pretty scary. So there's no rhyme or reason to it. Things that you want to think about for this is a central retinal artery occlusion. So it's like a stroke, but a stroke of the eyeball, okay? Risk factors, the same risk factors for strokes: diabetes, hypertension, dysrhythmias, AFib, pretty common, all right? So it's a stroke. The problem is, depending on where you work, do you treat it like a stroke or is there nothing to do? Those vessels are so small, we can't go in with a wire and remove the clot. The risk of using the clot busting drugs like we use in heart attacks and strokes is fairly high. So doing that for just one eye is limited. Some places are doing that in trials now. So the question is, what do you do with that? So some places are putting these guys in hyperbarics, and you're seeing some outcomes with that. Some places are using low dose T and K, but again, most of that is experimental. So it's really a tough thing. In reality, what we do in healthcare is we're like, yep, it's central retinal artery occlusion. I've ruled out other big bad things. There was no big stroke that we can manage. There's no underlying globe injury, no aneurysm, nothing like that. And hopefully you'll get better. See your doctor in 3 days. So pretty sad because you can lose pretty significant vision with this. But central retinal artery occlusion is a thing. It is out there. I would still advise, if it was me or my family, I would go to the local ER, make sure everything is fine from that standpoint, and then you do want to get in to see one of the specialists to see what they can do it. And again, some stroke centers actually have ophtho-neurology. What's the fancy name for that, Sullivan? You remember what they call that group? Is it ophtho-neuro? I forget. It's a fancy name. They wear suits and ties, and they make more money, and they don't work nights or weekends. So I'm kind of bitter with them myself, but yeah. Yeah. So kind of like a stroke, but you don't treat it like one. So hopefully we'll get better methods to treat these things in the future. Branch retinal artery occlusion has a much better prognosis. So instead of having complete vision loss in one eye, I can't see it on my left eye. It's like, yeah, my periphery's gone. Kind of weird, kind of hazy. All right. Much better outcome with these folks. The other thing is, with this, better outcomes, it also is kind of like the red flags, like a TIA, a mini stroke. You say, oh, crap, I had that. Now I definitely want to go in and see this neuro-ophtho guy to risk stratify and see what I can do to prevent having a central retinal artery occlusion. So kind of a warning shot. There's some optic nerve disorders out there, ischemic neuropathy from chronic disease, chronic hypertension. Folks post-arrest can get this. You can get nerve compression from masses, things of that nature. We've always showed some trauma. Glaucoma, either acute angle that we talked about or chronic glaucoma, which is just due to aging and a decrease of that outflow tract of the eye. All those things are bad. And one of the ways you can look for that is do the swinging flashlight test, which has always confused me. But in short, what you're looking at is When you shine a light on one eye, both eyes should respond to it. So you shine it on one eye and you're looking at both eyes, they both should what? Constrict, right? So you move it over, give it a second, and do the same thing. You want to make sure that the eye receives and transmits the fact that it should constrict. Retinal detachments, you'll see this in folks that are older or diabetics, folks with long-standing chronic hypertension, or just weekend warriors who go out and do crazy things and get small head injuries. Normally they're going to describe, they see flashes of light, and then what that is that retina comes off the back of the eye. It does a a mechanical reaction, and the eye thinks it's seeing something. So they'll say, yeah, I saw stars, I saw fireworks for about 5 or 6 minutes, and now I got this floating thing and curtain in my eye, and I can't see real well. That's a retinal detachment. That should go to an ophthalmologist pretty quick. We can reattach those. I say they can reattach those, and you can get the majority of your vision back if you do it soon. If you wait till after the Alabama-Auburn game to get that done, probably not as good an outcome, right? Vitreous detachment, sometimes the gel will pull away from the retina as well. And what you'll see is somebody would describe waves in their eye, not really a curtain, but they'll see waves. And when they move their head or shake the head, it kind of moves. It's like debris in their eye, okay, or dirty sunglasses. Things that cause that, old age, diabetes, obviously trauma can cause it as well. It's like a retinal detachment, but it's just the gel is pulled away from the retina instead. So better than a retina, but still not good. You can also get blood in the eye, and that's from diabetes or hypertension. What happens with that is the body reacts to chronic ischemic in the eye by making new blood vessels. Those new blood vessels are weak and frail. They'll pop and you get blood in the eye. So people say, it looks like spider webs or cotton in my eye. And every time I move my head or look down, it just kind of looks like a lava lamp. Okay? That there needs to see an ophthalmologist. The good news with that is there's some treatments for that. They can manage that. May not be completely vision loss for life, but still needs to see an eye doctor. You can look with an ultrasound at some of these things on the eyes and kind of gives you an idea what's going on. You can say, is the retina detached? You can also look and say, oh, look, there's blood in the eyeball. It gives you an idea of what's going on. Or you can look and say, oh, look, there's chunks of blood and something big, weird floating in the eye, and you think it's the vitreous. So there are ways you can kind of diagnose this with an ultrasound to give you an idea of where you need to go as well, if you know what you're looking for. I've always shown that picture. That one was gross. Just a quick review of head injuries. Remember, we talked about one of the big things with these open globes or major eye issues is think about head injuries. Remember, with any head injury, the 3 mainstays of therapy that we're going to do for these guys is prevent hypoxia. Hypoxia is bad for secondary brain injury. The dude with the nail in his eye, whatever part of the brain the nail hit is gone. You can't fix it. It's dead. Our job is to keep the area around that nail from dying. And we do that by preventing hypotension, controlling hemorrhage, preventing hypoxia. And if this person does get on a ventilator, get intubated, you do not want to blow off CO2 because CO2, when you blow it off, constricts vessels and makes the brain kind of get hypoxic as well. So prevent hypoxia. If they're bleeding, you can give you medications for that, your TXA. If you're a blood program, they get blood products. All right. If they're intubated, you're keeping your intake of CO2. Classically, they say 30 to 35. I like 35 or better. I think you want normal CO2, but talk to your medical director on that one. So different types of head injuries. You got epidurals, which are arterial. Those are bad. On CAT scan, they're nice and pretty. But when you see that, you should already be on the phone with neurosurgery and moving that patient to the operating room. Subdurals are venous. All right. These are more common in older people who get atrophy. Folks post-stroke, as the brain shrinks, for folks who do drugs or the brain shrinks, you get more pressure on bridging veins, and these subdurals are more likely to occur. And remember, people on anticoagulation, those two things increase the risk as well. This is your little old lady from the nursing home that fell 3 days ago that is now more confused. It's a subdural. This is more the acute person who got hit in the head with something. They passed out. They woke up. They said roll tide. They got a beer, and about 30 minutes later, they started seizing and posturing. That's that guy. You can also have intracranial, intercerebral, or subarachnoids, and I won't really cover those. We already talked about the 3 things to remember with head injuries: prevent hypoxia, do not blow off that CO2, and then prevent hypotension, because hypotension is bad. And if you want to Google the EPIC study, I think it's probably one of the most revolutionary studies out there that changed the way we manage head injuries, and was done by EMS providers out west. So super important study. I show this in a lot of classes I do for a couple of reasons. One, it's fairly inappropriate and funny, and two, it's kind of serious, right? So the difference between the doctor and the EMT, anybody see the difference? The doctor has bigger arms, so that's me, right? That was funny. That's the funny part. The not so funny part is this picture here on the side. So calling paramedics, advanced EMTs, EMTs, healthcare providers is like calling this dude a day laborer. He's not a day laborer. He's a tough guy, right? We as healthcare system people, the hospitals, physicians, we should be the folks supporting you in EMS, and we have failed in that. So we as a group got to do better. So 3 rules that I try to live by. I don't want to kill people. You go to jail for that. I want to do what I can to help folks. I can recognize you have an open globe injury. I can't sew it up. If I sew it up, you're going to be worse off. But I can recognize it, and I can get the right person on board to take care of that. All right. And you can do that too with your patients. You can figure out what's going on with your patient and get them to the right place, the right hospital, and do the care that you can do. And I want to go home with a clear conscience, because sometimes even when we do everything right, bad things happen. And the way I kind of follow these 3 rules for me is I train every day, all the time. I'm always thinking about the scenarios. Even after 30-something years of ER work, I'm still thinking about that next patient and what I can do better. Because when you make a mistake, or even when you don't, and there's a bad outcome, you feel bad about it, right? I pulled this off y'all's webpage, so forgive me to Prattville for pulling stuff off your webpage, but I do this to make a point. Prattville does a fantastic job in everything, but if you look at your numbers, total calls for 24, and you can pull up any any fire department in our state and do this. Total calls versus EMS calls. What percentage of your calls are EMS? More than 50%? Good. I'm from Mississippi. I can do basic math. More than 50%. You know what I'm saying? We don't have football or baseball. All right. We do have meth in Mississippi, just like you guys, though. So we're kind of cool. My point to that is look at your percentage of EMS calls versus your other calls, and then look at your number of training hours. And then you internally decide, are you spending 50% of your training on EMS or the appropriate amount of training on EMS? I know a lot of places do. I know some places do not. I understand that the fire side, you have other responsibilities. You guys are the catch-all for everything for the community. You are everything. I get that. But the community also expects you guys to be top-notch healthcare providers. That doesn't mean you have to be physicians, but it means that you need to practice to your scope of practice. So the medics should be medics, the advanced should be the advanced, the EMTs should be the EMTs, because the health system really needs the work that you do. So look at your numbers, look at your training hours, and see if you're meeting where you need to be. If you're not, please reach out. We're happy to help. The Fire College has been a great support for EMS Challenge. We would love to help take some of the load off of your regular training. And leave you and your EMS officers to do in-station training, things that are the important things one-on-one at the station level. So we're happy to help. If you need help, just reach out. There's that QR code again for the QI stuff. If you're interested, no obligation. It is free. I'm not selling you nothing. And that's all I got. Questions, comments, or statements within reason?
Hey, Doc, we had one question come in. It's pretty good.
Yes, sir.
So can you get a vagal response or other cardiovascular responses from eye injuries?
Yes. I would say yes. Yeah. There's even some, I forgot what it is. You can do, there's a reflex where you can push on the globe and they'll pass out and do things. But again, my rule of thumb is I usually don't poke eyeballs anyway. But yes, you can get a vagal response from that.
Okay. And so part of the other discussion that's kind of been going on is, so if you're in a remote part of the state that doesn't have easy access to specialized emergent eye care.
Yep.
And you have an obvious isolated injury that's severe, like a ruptured globe.
Yep.
Is there any part of the trauma system that addresses that to triage patients to, say, Callahan and Birmingham, or to centers in Huntsville?
Yes, sir. To my knowledge, the answer to that is no. I think that you're going to have to pre-plan for these events so you know where to go. Your local hospital can arrange transfers for you. That's what they should do. They should stabilize that patient, recognize that injury, and move them to the appropriate place. I know that our location, the Carolina Eye Foundation, their trauma patients go to UAB. So they will take isolated non-trauma eye. So if you had a acute angle glaucoma, yeah, they'll take that and transfer, but they probably would not take an open globe because their fear would be there'll be some underlying injury that they can't manage without the main services. I know the state folks are yeah, so I would go to the local ER.
Yeah, is there any restrictions from the pressure issues on the eye for flying these patients?
Not in Alabama. No, we don't. No, we're not Rocky Mountain. Some folks are Rocky Mountain High. We're not Rocky Mountain. Sorry, that was funny too. Maybe not.
That's all we had online. Everybody, we're going to take a few-minute break, and then we'll come back with Dr. Sullivan's going to be talking about toxicology. So stretch your legs. Don't go away. If you're watching us online, we'll be right back with you.
Hi, I recognize that I am being given the pre-lunch lecture, so we'll try to make it fast, interesting, high yield, and not try to keep us too far away from that. But I'm Tyler Sullivan. I am one of the EMS fellows with UAB, Birmingham Fire and Rescue. It has been a lot of fun and an honor to get to work with you guys and try to help y'all be better at your job and therefore help the communities that you serve. So we appreciate you guys. But this is one of my favorite topics. Early on, it wasn't because there was a whole lot of pathophysiology. It was a tough subject to test in medical school and all that. So I hated all this. But now that we're actually practicing and taking care of these people, I think this is a fun thing to deal with. Comes in as a mystery with just a few clues that you can kind of sort things out and really make a difference and see a tangible change in the clinical presentation and the progression of your patient. So these are fun for me. I enjoy taking care of these type of patients, and hopefully you will too by the end of this. I guess before we start, there's no financial disclosures from me. I would love to have some, so if you have any offers, we can talk after this. I just got back from a hunting trip. It was about an hour and a half from the Canadian border. So by the time I made it back from there, those things always cost double or triple the amount that you sign up for. So y'all let me know if you got any offers for me. Anyway, so toxidromes, toxicology today. The biggest goals of this is to help you recognize what's going on in the field. Oftentimes these are going to be call outs as altered mental status, something vague along those lines. So you're going to come in and feel a little bit like a detective in these situations. So recognizing toxidromes, identifying critical findings of said toxidromes and hallmarks that make you or enable you to differentiate one between the other, because at the end of the day, a lot of them are kind of similar. And then applying management per protocols. Obviously, this is geared towards the Alabama state EMS protocols, but there may be some nuances with your individual agencies that you need to be cognizant of as well. But all of the stuff in here, recommendations are going to be from a broad perspective, and then I'll have the Alabama state EMS recommendations as well. And then I've got a few cases at the end. If we're in a good position on time, we'll run through some cases just for more reps on recognition. We'll see how we're doing when we get to the end of this. And like I said, I want to emphasize pattern recognition on these because they do present, there are always key findings, hallmarks that you're going to be able to see to differentiate and figure out what we need to do. We'll start here with antimuscarinic anticholinergics. I think I started here just because this is one that I've seen most commonly in clinical practice, whether that is an accidental overdose or an intentional one, aside from opioids. Obviously, that's the number one cause, but I'm sure everybody in this room knows what to do with an opioid overdose, but we'll talk about it anyway. But let's start with this presentation. More specifically, let's put this in the setting of Benadryl. That's going to be one of our most common representations of the antimuscarinic anticholinergic side. TCAs are another one that are pretty classic, but TCAs are kind of falling out of favor as far as like being used for an antidepressant. You still see them used for various reasons like neuropathic pain and sleep aids, but like I said, those drugs are starting to become less and less common, but they're still out there. So what are these? Like we said, Benadryl, diphenhydramine, atropine, TCAs, and then Jimson weed. I've never seen anybody. I don't know if there's even Jimson weed in the state of Alabama. Maybe, but I don't know. It's in the textbooks. Anyway, to put it simply, it blocks the particular acetylcholine receptors, the muscarinic type, which lead to your classic toxidromes. Like we said, diphenhydramine, cold sleep medications, TCAs are your most common. And then these plant exposures, they happen. So clinical findings, I like to say red as a beet, dry as a bone, blind as a bat, mad as a hatter, and hot as a hare. So how does that actually present in one of your patients? That's going to be someone who's hyperthermic. They have a temperature 102, 104, 105. They can get really warm. They may have visual complaints, but if they have visual complaints, they probably have a whole lot of other stuff going on, and they're not able to tell you, like, oh, my vision's a little blurry. Usually this presents with some form of altered mental status. Dry skin, an important one to note when you're differentiating between this and like a sympathomimetic like meth or cocaine or something along those lines. These people have dry skin instead of sweaty. When they get to a kind of a severe part of their poisoning, they start to have hallucinations, they start to seize. You see these big hemodynamic changes in urinary retention. Important point with TCA overdoses and Benadryl, once you get further down the line, you can see dynamic EKG changes, particularly QRS widening, which can put you at risk of ventricular arrhythmias and death. So that's how people die from these things. I thought this was a pretty good schematic to kind of show you the classic findings. Starting from the top, you'll see a lot of confusion, agitation, and delirium. I had a Benadryl overdose the other night. The way that her parents kind of clued themselves into what was going on, at like 2 a.m. they got up and they found their kid like in the kitchen swatting at rats, which there were no rats, but she was chasing rats around the kitchen. They while they were trying to figure out what was going on, they called EMS. They lived rurally, so it was kind of a prolonged presentation from the crew. They were able to go into her room and found a big bottle of Benadryl that was essentially empty. So they were on top of it even before the EMS crew was there. You'll see them get dry mouth, cotton mouth. You'll see tachycardic, hypertensive patients. If you're listening for bowel sounds, they'll have diminished bowel sounds because of the blockade. It stops the kind of the bowel function. And same premise, these people will not be able to urinate because of those pathways. They will have hot skin along with the hyperthermia, but like I said, it'll be dry. In toxicology, we use this thing called the toxicologist handshake, which is sticking your hand inside someone's armpit that you suspect some kind of toxidrome to see if they're sweating or they're dry. If they're dry, you can kind of move away from the sympathomimetic side and more into this realm. And then other things like we talked about, I'll show you in just a second, some EKG changes, dilated pupils. These people are going to have dish saucers for eyes. So those are kind of the classic hallmarks. For me, is a altered patient with dilated pupils, warm, dry skin, and elevations in their vitals in the way of tachycardia, hypertension. This is in a TCA overdose. This is the classic kind of findings that you'll find in a severe overdose. This in particular in AVR is where we want to focus. As you can see here, this is called a terminal R wave. So you see this funny looking QRS here, but you see this huge upslope and like a downslope here in AVR. That's kind of bonus point finding if you see that in the pre-hospital setting in one of these patients. At this point, you need to have bicarb pushed like 10 minutes ago. Anyway, that is the classic presentation as far as EKG goes. So the why behind that, so TCAs in particular and high dose diphenhydramine or Benadryl acts as this like quinidine-like sodium channel blocker. So you get this big sodium channel blockade that affects depolarization in the heart. And without getting too into the weeds on that, how that manifests is that terminal R wave. You also see this big widened QRS on EKG, which can predispose you to torsades and other ventricular arrhythmias. So that's kind of the why behind it. You also see potassium channel blockade with this, mainly TCAs. And again, this is in more of a high dose deal, but the main mechanism behind this is the sodium channel blockade. So like we said, how do you fix that? You're pushing sodium bicarb. What it does is it increases the pH of your blood, and it also increases the sodium concentration. Helps you kind of with the pH change, kind of helps you prime the sodium channels for alteration, and then you get your sodium in there behind it that helps you offset the blockade. So kind of a synergistic effect on how that works for your cardiac myocytes. So as far as general management, this is going to get a bit redundant. A lot of this is going to be like supportive care, benzos, hemodynamic management, and airway management as needed. So if you have someone like this, supportive care, external cooling, right? If they're hyperthermic up to like 107, like to the point where this is going to be an issue, try to cool the patient, get things off of them, get them exposed, ice pack in the crevices and things like that if necessary. But typically, you're not seeing some kind of crazy temperature, but if you are, consider some external cooling. Benzos are big here. The patient that I was referring to the other night, she was very small, probably 100 pounds. And she had chewed through like 16 or 18 milligrams of Versed before I transferred her to Children's, and she was still rolling, heart rate of 140. So a lot of benzos can be necessary, but I typically go low and slow with these, either in aliquots of like 2 milligrams or 4 milligrams, IV or IM, whatever you got. For her, I was giving her in doses of 2 just because her small weight made me a little nervous, but these folks can really chew through it. As we talked about with a TCA overdose or high-dose Benadryl, if you get an EKG, which you should in your initial workup with these, if you see any form of abnormal QRS, and particularly in a TCA overdose, have a very low threshold to give sodium bicarb here because it could be life-saving. And then the pearl, just to drive that home, if you're thinking anticholinergic or there's some possibility of a TCA or Benadryl versus a cocaine meth or something like that, think about their skin, dry versus wet. That can help you. That can help you pass along a meaningful bit of information to your hospital colleagues, and also help you in your management. So to bridge the sympathomimetics, as stated, this is more of a cocaine, meth, MDMA, bath salts were high profile for a while. There were folks running around eating each other, doing bath salts. I don't think we see that. I don't know if y'all seen that a whole lot around here, but you hear about it, you think about it. It's crazy when it happens, but that all falls kind of under the realm of sympathomimetics. I think commonly you'll see somebody like, that's prescribed Adderall, either, for an actual diagnosis or otherwise, and they've taken too much and called EMS because their vital signs are running crazy and they're having palpitations. But a lot of meth, a lot of cocaine running around out there as well. Caffeine, synthetic stimulants like designer drugs, those are kind of some other ones. You don't typically see somebody get a hold of enough caffeine to send them into one of these toxidromes unless they're hitting a bunch of pre-workout, going to the gym or something. And typically those people are fine. So that's kind of the list. So what do you see? As expected, you would see hypertension, tachycardia, diaphoresis, sweaty, agitated, dilated pupils. So very similar to the antimuscarinic presentation as well, just with the sweaty skin. Late in the game, you start to see significant hyperthermia and seizures. As far as vitals goes, as discussed, you see everything's going to be elevated. So they're in total sympathetic overdrive. They're ready to fight or run away or do whatever your kind of lower brain is trying to get you to do to survive. We kind of talked about the physical exam. Starting from the top, you're going to see big dilated pupils. It's sweaty, so they're going to be drenched. Agitated patient, very anxious, paranoid, hallucinations, all the way up to seizures. Tremors, hyperreflexia, so everything will be jittery, as you would expect. Kind of some of the severe complications of this is too much stimulation of the muscles, so you can see down the line like rhabdo. But the most important ones with a sympathomimetic, which is how DMX died, If you know the rapper, he died somewhere over in like Eastern Europe after a cocaine-induced MI, which is impressive. But you can also see, if you're way down the line of this, any of the classic like hypertensive emergency type situations, such as flash pulmonary edema, aortic dissection if you're predisposed to that, or hemorrhagic stroke if you've run your pressure up to 300 in the acute setting and something happens and you're predisposed and have an aneurysm or something like that. Most commonly, you're seeing seizures, hyperthermia with like rhabdo, and then end organ damage like kidney injuries, cardiac ischemia that's not a clear MI, things like that from the severe hypertension. So like I said, just another drive home point to differentiate between the two. Look at their skin. They're going to look the same. That's kind of a quick mnemonic for sympathomimetics maths. My brain does not math very well, but mydriasis of big pupils, agitation, tachycardia, all the hypers, seizures, and sweating. So, like I said, redundancy here. Management is your first line's benzos. 2 to 4 milligrams IV IM, repeat as needed. Cooling measures, if they are significantly hyperthermic, IV fluids is a good thing. Like a liter is a good situation or a good idea in any situation where you suspect this. Monitor for any of the complications as discussed of severe hypertension. So if the patient starts complaining of severe chest pain, if they start having trouble breathing, things like that, start thinking about those end organ damages, all of those complications that come from the massive increase in sympathetic tone. What to avoid? You may be tempted in these situations to say like, oh, their heart rate is consistently 150, 160. I'm going to give them like some metoprolol. I'm going to give them something to slow this down. If you give them a selective beta blocker that does not cause any alpha blockade as well, propranolol has a little bit of that crossover, but what we call the A-beam beta blockers, so like atenolol, metoprolol, and a couple of the others, they selectively block beta, and so they can leave some alpha stimulation in there, and you can get unopposed alpha stim and make this worse. There was a couple of resources recommended, very judicious use of restraints in these situations just because of your increased risk of muscle damage. I think it's more about your safety. So this is in here on the chart. So if you need to restrain somebody, chemically restrain, and even up to and including intubate, if they're going to hurt you or cause more damage to themselves, these are situation dependent things. So use restraints if you have to, but that was out there. This is personally one of my favorites, serotonin syndrome, because it's a really interesting, very unique physical exam, and it's something that you can make a huge difference on very fast. These are typically sad situations. Most people don't overdose on their SSRIs accidentally. These are typically intentional overdoses. You'll see these occasionally when someone gets a hold of something that they don't know that they're taking. I had a guy present in essentially this way after taking some of like the gas station kratom and gas station like synthetic weed. Very strange, but had all the hallmarks of SSRI and responded just as someone that has serotonin syndrome would. But anyway, these are cool. These are fun. So if you have a patient that presents that has, say, altered mental status, something like that, or a suicide attempt, and somebody on scene gives you a history of like, yeah, they have severe anxiety, they have a depression, here's their medical or their medication list, and you see an SSRI. So like you see whatever Prozac on there or one of the other kind of common antidepressants, and you see an altered person with the toxicology that we'll talk about. I want you to be thinking about serotonin syndrome. So this comes on pretty quickly after the overdose, so within hours, versus its counterpart, neuroleptic malignant syndrome, or NMS, which we'll talk about, which happens over days to weeks. So this is an acute phase. They were normal a couple hours ago. They went to the room for a few hours, they didn't see them overnight, and then now they're altered and acting weird and doing all this stuff. So what do you see in a patient with serotonin syndrome? Kind of the biggest hallmark is you're going to see these dish saucer pupils, just as the others. You're going to see big dilated pupils, and you'll see what's called clonus. Clonus is a very interesting one, and very cool when you see it. You don't see it too frequently, and pretty much limited to these situations. So in a mild overdose, you'll see those big pupils. That's one of the first things. And you'll see some kind of sympathomimetic type symptoms. So you'll see an elevated heart rate, be real jittery, lots of sweating. They can have increased reflexes at this stage as well. Once you start moving on down the chain, you start to see this altered mental status. You start to see more of this hyperreflexia, heightened startle, everything that has to do with that same sympathomimetic surge. You're getting that in these patients as well. Then you start to get into this full-fledged delirium, hallucination, all of the elevated vitals that you would see in the others that we've talked about. But then you also see this clear-cut hyperreflexive neurological exam. So you tap on their knee and they just about kick their leg off the bed. The way I like to do it is I'll literally like take my hand and put it on their thigh and take a finger and tap here. And if their quad is jumping just at the tap of a finger, like I'd call that hyperreflexive. And then for clonus, I may have a schematic here. So I couldn't get the video to work when I was building this PowerPoint, but the way that I look at clonus is I'll take their foot, kind of get them to relax, and you pop up on the bottom of their foot while holding it. You hold pressure there. So if I can kind of explain here. So I'll take their leg here and I'll push this up like that, and it'll start bouncing. Out of their control, nothing that they're doing, their foot will just sit there and tap, like they're tapping their foot on the floor. A lot of times you'll see it 7, 10, 15 beats, and it'll kind of stop. In severe overdoses, it will continue in perpetuity, like you start it and it won't stop. That's the hallmark classic finding of serotonin syndrome. The rest of them can blend, right? So you have dilated pupils, a sweaty patient, hypertensive tachycardic, altered, hallucinating, all the things that you've seen in the previous 2 toxidromes as well. So you can really look like a rock star. You roll up in the ER and they're like, hey, this is an altered mental status. We suspect overdose, and they've got clonus. We're suspecting serotonin syndrome. So why does this cause these classic findings, right? So these drugs work in the central nervous system, particularly SSRIs, to block the reuptake of serotonin. So you get this big excess of serotonin in the synapse, and you get hyperstimulation of all this stuff in the CNS. Some little receptors that isn't really relevant to you guys and really isn't relevant in clinical practice, but knowledge of them, the 5-HT1A and HT2A receptors, are one of the places that your body primarily in the CNS generates kind of like a hyperactive neuromuscular response, which is where you get this hyperreflexia and the clonus from. So those are the receptors that are giving you this big sympathetic surge, as well as the hyperstimulation of the CNS that you're seeing. As stated, the onset for serotonin syndrome is within hours, as contrasted with an MS, which is over days to weeks. The management here is to obviously stop the offending agent, benzodiazepines, supportive care, cooling for hyperthermia. Cyproheptadine is on here. Don't typically give that. I've never given it despite taking care of serotonin syndrome many times, but it's still there in the kind of the management on the hospital side. But oftentimes the toxicologists are not recommending this. It's just supportive care and benzos. Then getting them to the hospital. These people will oftentimes need an airway if it's bad enough, and especially if they're presenting late in the game. So close attention to their airway status is important. So just to kind of wrap that up, clonus, hyperreflexia, agitation, and then a concerning history of anxiety, depression, or documented SSRI in their medication list, think about this. And then briefly on NMS, this is rare. This is not something that I've seen maybe twice in my entire career. And it was obvious that that this was a concern in both those patients, and that's why I was able to pick up on it in the ER rather than days later. So NMS is antipsychotic and dopamine blockers. So this is more of your Parkinson's type patient that maybe stops all of their medications and then restarts them. The difference here is all of the same stuff, right? Hyperthermia, altered mental status, elevated heart rate, elevated respiratory rate, all of those things. But you see this lead pipe rigidity, which means like their extremities are stuck. Like you can't really bend their arms, their legs, and they generate a hyperthermia because of that, because they have this constant muscle tension. Like I said, this is not a super common one, and one that I would not expect you guys to pick up on, but is there, because oftentimes we don't even pick up on these in the ER unless they're blatantly obvious and we have the history. So as a kind of a comparison between the two, they're both kind of managed by supportive care, oxygen cooling, and benzos. The onset, physical exam, and then your history with the patient can help to differentiate between these two. We all know about opioids. This is nothing new. Every single one of you is going to see this multiple times, maybe even every time you go in for a shift. Coma, pinpoint pupils, respiratory depression, hypotension, hypothermia, hyperreflexia. Narcan is the answer here. Our updated protocols, Narcan 2 to 4 milligrams, IV, intranasal, intramuscular, however you got it, every 3 minutes. And then for pediatric 5 years or greater than 20 kgs, you can do 2 to 4 IV, IN, or IM as well. I guess the drive home points here, I won't beat on opioids too much, as we know, is just make sure you're managing the airway early, whether that's assisting with BVM while you're giving the Narcan, or if you're too concerned about this, managing airway with an IGL or intubation. From a cholinergic standpoint, this is a little bit more rare, but these can be very interesting when they happen. So cholinergic can kind of entail a lot of things, much more rarely, like carbamate insecticides. A lot of the mainstream insecticides are going away from that. Nerve agents, as in like when you see the Russians like assassinate somebody that's exiled from their country in like Spain or whatever, like you'll see these like VX, sarin. Sarin is more of an older one that was more of like World War II, World War I, chemical warfare. But one place that you'll see some of this now is in assassination attempts, typically by government agents and things like that. Would not expect to see a whole lot of that around here. Potential agents, as far as medication goes, donepezil, rivastigmine, galantamine. So you can see these being taken by patients in like early, well, I guess like any stage, Alzheimer's or dementia, but you'll see these particularly in early stage when people are first concerned about them. They start them on these kind of nootropic medications to try to help slow that process. So those are potential causes, as well as pilocarpine or bethanechol that are used for glaucoma, which was mentioned earlier, as well as urinary retention for people with neurological or like neurogenic bladders. I think the most relevant one is organophosphates. Yeah, this is a very common cause of this worldwide, especially in like less developed countries where agriculture is much bigger and less regulated. So some of the old school organophosphates, insecticides are out there. And like I said, outside of the United States are much less regulated, so therefore controlled a lot less, much more prone to accidents and accidental spills and things like that. It is also not a rare way that people commit suicide worldwide. It's a strange one, but that organophosphates is kind of going to be the focus in this particular section. So what do we see with these? If you have a known agricultural accident where this is a possibility, the patient's going to present with a couple of hallmarks. So we use sludge. So the S in sludge is for salivation. So they're drooling uncontrollably, like running out of their mouth no matter what they can do. It's even as much to compromise their airway. So like they're aspirating this, unintentionally, uncontrollable salivation is pretty profound. So lacrimation, you're getting a bunch of tear production, urination. You see people lose kind of control of their bladder. They're running off with diarrhea. They're having bad GI upset, bad stomach pains and cramps, and they're vomiting. So everything to do with kind of like fluids that come from your body, it's upregulating all of that stuff, and they have issues with that. The killer bees for cholinergics, bradycardia, so it slows heart rate, gives you a big cholinergic surge, which is almost equivalent to like a parasympathetic type tone. So the sympathetics is raising your tone and the parasympathetics are bringing it down. So you wind up with bad bradycardia that can predispose you to an arrhythmia, bronchorrhea, and bronchospasm. So you can get bronchospasm to the point where it's like a severe asthma exacerbation, and then bronchorrhea, you can also wind up with a bunch of airway secretions and things that are inhibiting your ability to breathe as well. This you'll see meiosis, so as opposed to mydriasis, meiosis is the fancy word for constricted pupils. So interesting schematic here, just kind of the classic findings, right? So sweaty patient, so more body fluids, pinpoint pupils, frothing at the mouth, so lots of secretions from the upper airway, runny nose, lacrimation, throwing up and having diarrhea, they're urinating uncontrollably, and their heart rate's low. So how is that managed? So if this is suspected, the most important thing is for you to protect yourself, because this stuff sticks to clothes, skin, and it doesn't go away. And if somebody goes in, trying to help, touches the patient, gets all that stuff all over them, they make themselves sick too. So now we're compounding patients, and we don't want to do that. As stated, the organophosphates are the #1 cause worldwide in agricultural, suicides, things like that. So anytime you're responding to a scene where this is a concern, obviously you guys know how to do this. Scene safety and taking care of yourself is what you want to take a top priority on, because if you get hurt or you get exposed, now there's more patients and less help. High priority in these patients is airway. They are going to get in trouble with it. So in the very least, it's supporting them with non-rebreather, high flow oxygen, however you want to do that, and based on how they're managing their airway, high priority. Atropine is going to be what is in our protocols and what most of you guys are going to have handy. The other antidote, prelidoxime or 2-PAM, is not something that I think is routinely carried. You may have it depending on your agency, but it is not currently in the protocol just because it is not very commonly carried. But atropine is going to be the one that you want to go for in these situations, because they decrease all of those things that we're talking about, right? They decrease the salivation, the bronchorrhea, they slow down bronchospasm, so they can help people maintain their airways until you get them to a hospital where there's more definitive care. So that dose is 2 milligrams, either IV or IM, every 5 minutes. I wish I would have found it for this lecture, but there's a picture out there of a patient in a community rural hospital where they used all of the atropine in the hospital, and there's a patient laying on a stretcher, and then the stretcher next to him just had boxes of atropine where they were redosing every few minutes trying to maintain this guy. So management, as stated, airway and breathing is the #1 priority, because this is the main and the fastest killer in these toxicities. Circulation, bradycardia and hypotension is going to be your progressive manifestation of this. So monitoring them via the cardiac monitor, having the pads on them, IV access, and then your inotropes and all of that as necessary. You want to run IV fluids early and support their blood pressure. Medications, the mainstay, as stated, was atropine. Large repeated doses are often necessary. Your goal with this is you want them to tolerate their secretions and you want to help them from an airway standpoint. As stated, the preladoxime is rarely available to you guys, but it works more centrally and helps regenerate the acetylcholinesterase, which is what's kind of blocking the reuptake of acetylcholine and causing this massive like parasympathetic type tone. But that's more of a hospital management. Transport to definitive care and alerting poison control and taking care of yourself, most importantly here. So airway, atropine, and protecting yourself is what you need to remember about these once you've identified it. So sedatives, CNS depression, slurred speech, ataxia, hyperthermia. Most commonly you're going to see in the field, this is alcohol and benzos. There's a number of medications that can do this, but I think the things that you're going to see on a routine basis are alcohol and benzos. And basically what you're looking for here is supporting their airway and ventilation, monitoring their vitals, intervening on hypotension as necessary. Flumazenil is out there for benzodiazepine. For like benzo overdose, this is typically used with like high doses that have hemodynamic effects. I don't think, do any of you guys carry flumazenil? It's more of a hospital thing, but it increases your seizure risk, so it's not routinely recommended. Hallucinogens, kind of self-explanatory. This is your LSD, your psilocybins, your synthetic marijuana, ketamine, PCP, that kind of thing. So you see just distortions in reality, hallucinations. These people can be wild, and they can also be running kind of a sympathomimetic toxidrome behind that with all of the classic findings there. Again, supportive care, benzodiazepines, kind of redundant management with these folks. Special considerations here, I wanted to throw these on. Calcium channel blocker and beta blocker overdoses. They're uncommon, but they're out there. We see them periodically, and they're pretty bad when these things happen. Most of the time, you see mild ones, like very mild ones, like isolated bradycardia that's not really symptomatic, and someone who accidentally double dosed on a very high dose beta blocker if they take it. But the bad ones are pediatric patients who take these mistakenly. They get into their parents' medication and take a bunch. And even if they don't take a bunch, like the dose, per body weight is much higher, so they're much more susceptible. And suicide attempts. People take a whole bottle of their calcium channel or beta blocker and get into trouble. A way to differentiate between these two, they present the same, right? So they present hypotension, bradycardia, altered mental status, all of those things. Beta blocker overdose will oftentimes result in persistent and recurrent hypoglycemia. So if you have a patient where this is suspected, getting a blood glucose can kind of help you differentiate between the two. And it's also something that you need to be aware of, which can be lethal in a beta blocker overdose. So immediate actions, just doing your standard ABCs, getting IV access and supporting them hemodynamically, contacting poison control. You can use atropine per kind of ACLS protocols for bradycardia, for symptomatic bradycardia here. Glucagon is inside of you guys' state protocols. So glucagon, 5 milligrams, either IV or IM. And for a pediatric dose, that would be around 0.5. If you are honing in on a calcium channel blocker, you can also use IV calcium. It is not wrong to trial that in pretty much any situation that you suspect one of these two. Calcium can kind of replenish the calcium that is deplete in a calcium channel blocker overdose, and you can get good responses with higher dose calcium gluconate in these situations. In the hospital, we'll put these people on like high dose insulin therapy, and that can kind of help with the cardiac effects and get them back going from that standpoint. But importantly for you guys, bad ones in pediatric and suicide attempts, recognizing, that this is a problem from the history and that this is likely, trialing glucagon early and then expecting like nausea and vomiting. Glucagon is is very classic to cause significant nausea and vomiting in patients, so taking precautions from that standpoint. And using vasopressors early, if you have epinephrine, if you have Levophed, or whatever you have on your rig, using that as necessary for significant hypotension. Carbon monoxide and cyanide, we'll hit those pretty quick. So carbon monoxide, I'm pretty sure this weekend in this like tiny wooded cabin that I was staying in up in the Northeast, I woke up every morning with a headache. So I'm pretty sure I was on the top bunk too. So I'm pretty sure I was just churning through some carbon monoxide all night. And then I got better after we got out of the cabin and went hunting. So I'm like, I think I was just having a little low dose carbon monoxide. Anyway, oxygen's the answer there. If you suspect that, the reason for it is carbon monoxide binds up your hemoglobin a lot tighter than regular oxygen will. And so everything, your oxygen delivery in your blood, the vehicle for that is bound up by carbon monoxide. And so you can't deliver oxygen to your tissues. So high flow O2 outcompeting the carbon monoxide is what you want to do there. Cyanide, this is your classic firefighter and medical mix. This is someone who was in a house fire, breathing all the nastiness from the house, and now has cyanide toxicity. If you have somebody that presents from like being prolonged and trapped inside of a house, they show any signs of hemodynamic compromise, airway compromise, it's not wrong to give them a cyano kit. Just be thinking about this. Alcohols and methemoglobinemia. This is very much so a hospital thing, but it's out there. If someone drinks methanol or ethylene glycol, you'll see like severe acidosis and methemoglobinemia from those things. Like I said, this is something that if you were able to jump on top of this based on you knew that a person ingested one of these things, otherwise getting into the hospital is kind of what we need you to do there. So bring all that together. A lot of these are very similar, right? So all the sympathomimetics, that pretty much runs through most of the things that aren't downers, right? So knowing a few of the hallmarks can help you differentiate between the two. So pattern recognition, like seeing these things, knowing what to look for, the few key elements that can help you differentiate between the various toxidromes can be key. Knowing your protocols, knowing that much of this is supportive care, but knowing your protocols and knowing your antidotes that you may have. I took this directly off of the state EMS protocols, and I think that's a pretty decent wrap up of pretty much everything that we talked about today. This is a good chart, but there's a bunch of good charts. If you ever want to look back through these to synthesize pretty much everything that I said into one chart, these are all of the common toxidromes that you may run across, or at least causes for toxidromes. And it'll give you a brief description of pretty much everything that's there that you should expect to see. So this is an easily printable card if you want to have these around to roll with you, just as a resource. I personally am a big fan of utilizing your resources. So I have several apps on my phone that I use on a daily basis. I have some cheat sheets on my ID tab that I use when I don't know what's going on, or when I'm in a stressful situation and I need to know specific dosages and things like that. I love to have things like this around. So anyway, we can open up for questions. I have a few cases we can go through, but we're getting kind of close. So I think we'll forego those for probably the questions that are going to come out after this anyway, and we can take any questions.
Okay, very good. So not a lot of questions, a few comments. One is that a lot of the insecticides that are cheap and readily available still are organophosphate.
Right.
So particularly what a couple of people have mentioned is the roach foggers. If people don't leave the area when they set off the roach bombs, you can see this organophosphate.
Interestingly, I know of an interesting case from one of our critical care transport guys down in the USVIs in St. John. There was a 3-level like condo complex. The second level, I believe, had been rented to a family. On the third level, they had set off one of those bombs and not communicated. And pretty much immediately that family shows up for their vacation, goes inside the condo, 2 adults, 2 children, and all of them were very badly affected by it, particularly the kids. And so this guy flew them out back to the mainland U.S. I believe a couple of them passed away. I think only the wife came out unscathed. So it was a really bad situation.
Yep. And if you get one of those, and I think you made this point well, you're gonna need more atropine than you have. It's gonna take a lot of atropine to keep those folks stable. On the cyanide, excuse me, that's something that we've been talking about a lot in the last few years about agencies carrying cyanokit. And just from my perspective, I think anybody in cardiac arrest at a structure fire scene should get cyanokit.
No question.
So any contraindications to that? Any way we could hurt somebody who's in cardiac arrest by giving them cyanokit?
Not if you have a strong enough clinical suspicion in a house fire. I don't think there's any reason not to give that unless you have something else, Dr. Ferguson.
I agree. Do your primary assessment, do your basic cardiac arrest care. If they're not responding to it immediately, cyanokit's the way to go. Right. So I know places that I work, the policy is altered mental status, respiratory distress, not responsive to initial therapies. And by responsive, I don't mean wait 15 minutes. I mean immediate response. They get the cyanokit. Limited risk, potential benefit. We've had some great saves in the greater Birmingham area with cyanokits on folks that cardiac arrest or peri-arrest, get a cyanokit, and they arrive at the hospital alive. Think about it. If you have cyanide poisoning and you don't use the cyanokit, every minute you don't use it, they are not getting oxygen. It's like putting a bag over their head. People don't do good like that.
So the other questions we had were about glucagon as an antidote or as a treatment for beta blocker and calcium channel blocker overdose. So I always worry about kids with that, like you mentioned, the little kids, but we also see people with suicide attempts. If it's an adult, there's not an EMS agency in the state that carries enough glucagon to treat it. Right. And glucagon is super expensive. If you're the purchaser for your agency, you know what I'm talking about. If you're carrying glucagon, it's probably over 50% of your drug budget. That's how expensive it is. So the question comes up then, is it worth carrying? What are your thoughts on that? I would say I think maybe it is just for the case of the pediatric overdose.
That would be. Like I said, these are not super common cases, but in the cases that they are, it can provide potential significant benefits. I do agree, but I'm biased. I'm a dad, and I always feel like the stakes are higher when I'm taking care of kids. And so having everything available for like the potential pediatric patient, I think is reasonable. But you guys have more experience with kind of the overall budgetary things, and so like there may be smaller agencies that don't have as large of a budget where if that like the substantial cost of glucagon kind of outweighs the benefits or even the occurrence of a beta blocker calcium channel overdose,
Yeah, I think you got to have a plan, right? So you got to have access to the medications or know that your local ER has it. I would bet my $7 I got left to make it to the first, right? That a lot of these local ERs don't have a lot of glucagon either. It's pretty expensive. I used to joke about even at UAB, if we had a beta blocker overdose, we'll be ripping out every crash cart to get enough. Now, I think things are different now because we have a pretty strong tox service. But that being said, have a plan. So talk to your local ER. Hey, do we have the resources to manage this if I had a 3-year-old that took that? And then you can make the decision, do we need to carry this? Do we need to just recognize this potential and get to the local ER? I mean, when you have this kid or adult that has this overdose, you can do your basic care anyway, which is oxygenation, ventilation. You're going to start your bradycardia support, whether it be an atropine or dopamine or epi. You can consider these calls, think about calcium. When you get the history of that beta blocker, that's when you got to know what your plan is. Either you have that medicine, which you probably don't because it's pretty expensive, or you know that local ER they have 8 milligrams set aside for emergencies that you can get there, stabilize them, and then fly them where you need to get to go. So it's all in the planning, right?
So related to that, for known beta blocker overdose, like say you had a 3-year-old that got into granddad's Pope roll, right? Took 3 or 4 of the little pills thinking they were candy. And you knew that would happen, and you didn't, or even if you do have glucagon available, what would be your first go-to drug of choice? Would you give epi microdose? Is dopamine even a consideration?
I mean, it wouldn't be dopamine, probably not be consideration of the kid. I think I'm going to be doing IV access, checking the gluten, do basic things, and somebody's drawing up some microdose epi, starting epi infusion on that kid in the hopes that it works, right? Because you can rescue these folks with just your normal care as well. It's just more challenging, right? So.
Yeah, I like epi for that just because of the synergistic heart rate and blood pressure support, but also considering atropine on the front end, just because it's such an easy dose. Especially if you're having to prepare like a push dose epinephrine or an epi infusion, hitting them with some atropine just along the lines of the ACLS bradycardia pathway.
Yeah. What's the dose of atropine in a kid? Anybody know off the top of their head? I got people crossing their eyes now, don't I? Yeah. So how would you figure it out? What would you use to figure it out real quick? How long would it take you to figure out that dose? You got Broslow tape? Yeah. So Broslow tape or PD stat, whatever you got. Yeah.
Yeah. I'm not paid by PD stat in any way. I wish I was. I paid them for that, $5 a year, I think, and it's money well spent. I took care of a kid that was like 6 pounds the other day, and I had to give him a bunch of medications, and guess who would not have known the doses on any of those without PD stat, and that was me. So this app, this is what the front page of it looks like. PEDISTAT. It has pretty much every medication that you need. You can plug it in by age. You can plug it in by kilograms, pounds, whatever you want to do. And it will give you appropriate doses for pretty much any situation. So I think that is $5. I would pay $50 or I would pay whatever to have that resource because I've used it in clutch situations. The Braslow tape is obviously a physical manifestation of that. So you should, without exception, have access to that. But I love having PStat. I love having all of that right there. It's dynamic. I don't have to lay it out on the table and do all that stuff. It's bailed me out a bunch of times.
Yeah. And the way to use that, though, is make sure that your whole team knows how to manage this sick person. So you got somebody managing the airway, doing the passive O2, somebody starting a line, getting the fluids, checking glucose, put them on the monitor, so that when you realize, holy crap, I got to give medicines to this sick patient, then you have somebody that can step back and look that up and give the appropriate dose, right? So it's got to be a team effort.
All right. Very good. We're out of time. Thank you, Dr. Sullivan. Great lecture. Thanks as always, Dr. Ferguson. Where are we going next, Dr. Ferguson?
We're in Chelsea on the 8th of October. I'll have those flyers. I'm hoping out tonight. I'll put it on social media tonight, even if the flyers aren't ready. And then the 22nd, I think, is the date, the fourth Wednesday. We're in Troy. And then November, we'll be at the state conference. And I think December, we're back in Birmingham. So Chelsea, then Troy.
That sounds right. Okay. If you're participating with us online, there's a link to the attendance form in the Q&A section. Please fill out an attendance form, even if you don't need the CEUs. Helps us keep track of who's participating with us in our program, and also gives us an opportunity to get feedback from you on what we can do better. If you're here live, we'll get you that form as well. If none of those mechanisms work for you, you can always send an email to alabamaemschallenge@gmail.com. You'll get an automated response with a link to the attendance form. The password for today's attendance form is TOXIC, all lowercase TOXIC. And we'll see everybody next time.